Marketing Department of South Jersey Healthcare, and it's a pleasure to have you here for our joint meeting seminar. How many people here in the room are familiar with us at South Jersey Healthcare? Well, it's great to have you here. South Jersey Healthcare is a growing health system serving patients in Cumberland, Salem, and here in Gloucester counties. And we have two hospitals, the South Jersey Healthcare Regional Medical Center in Vineland, as well as Elmer Hospital, right down the road in Elmer, just minutes here from Mullica Hill. We also have more than 40 outpatient locations like we have here at Tomlin Station with a variety of services and convenient locations throughout our community. And Tomlin Station Park, where we are tonight, is the latest example of one of those centers where we're providing convenient care for patients in their communities. And here at Tomlin Station, we have an urgent care center, an imaging center where you're sitting right now, rehab care that provides physical and occupational therapy, primary care physician office, as well as orthopedics provided by Premier Orthopaedic Associates, who one of our physician guests will be joining us from Premier tonight. We're excited to have them here with us as well. So it's a comprehensive center, particularly for orthopedic care, which makes this joint meeting seminar appropriate at this location. So if you can imagine that you have a child or a grandchild who's out playing soccer on the soccer field and they twist their ankle, Tomlin Station Park is a great place to provide comprehensive care for those types of injuries. They can be seen after hours for a quick diagnosis in our urgent care center. If they need an x-ray, it's right here at our imaging center. If they need a follow-up with an orthopedic physician, Premier is here to serve them. And if they need follow-up care after treatment, we have physical therapy as well. So providing all of that comprehensive care in one location is something that we're proud to do at South Jersey Healthcare, and we're excited about the ability to do this here in your community in Mullica Hill. Just a couple of other things I'll mention about South Jersey. At our Regional Medical Center in Vineland, some of the services that we've been growing there as well. We have a comprehensive cancer center, the Regional Medical Center that's partnered with the Fox Chase Cancer Center, where we provide all cancer services in one convenient location as well, from radiation therapy to medical oncology and specialist care all in one building, which provides great convenience for our patients. We're also in the final phase of construction of a neonatal intensive care unit at the RMC that we're very excited about. That's going to open this spring. That will allow us to treat babies here in our community born as young as 28 weeks, which provides great convenience for parents so that they don't have to travel into Philadelphia or Oakwood Bridge when they have a child born in the family who needs that special care in the NICU for an extended period of time. And we're also very excited that South Jersey Healthcare has become a teaching hospital. We now have residents at the Vineland facility as well in a number of specialties, including family medicine, OBGYN, and orthopedics as well. And I mentioned Elmer Hospital. Some folks in the room, hope they're familiar or have been to Elmer Hospital. Elmer's been providing care for Gloucester County residents for many decades. It opened in the 50s. It was built there by community members in Elmer. And a lot of services have provided care in Elmer for people who live in Gloucester County close to that hospital all the way up here to the Mullica Hill area. And you may have heard also that South Jersey Healthcare has been talking with Underwood Hospital about a potential merger, and some news recently that we did file merger agreements with Underwood and applied for approval from the state and federal governments. We're very excited about that. Hoping here mid-year we get approval for that because it'll allow us to expand our coverage and provide even more quality services to folks here in Gloucester County. So I invite you to learn some more about our health system. We've got some information over here. We also have our friends from rehab care here tonight. They have some information about our services here. We have information about imaging and the health system, and that's all right here at our table here. So please help yourself with some of that information. I see a lot of you have helped yourself to refreshments already, so please eat that all up so we don't have any left over. And we also have in the bags of information that we provided with you tonight a survey. And I also ask that you fill that out and hand it to either Robin or Suzanne or myself. There's Suzanne over there and Robin's in the back. It helps us to plan these sessions in the future and provide topics that are of interest to the community and kind of get an idea of what it is that you would like to hear about at these types of sessions. So it would be a great help to us if you'd take a look at those and fill them out. So moving on to our presentation, we developed the South Jersey Healthcare group that's called the Orthopaedics and Spine Specialty Group. It's 16 physicians who bring a lot of talent and experience and training to our hospitals and to the community. And we're very proud to partner with them because they bring cutting-edge minimally invasive procedures to our community that once required trips to a big city hospital can be done right here in the community. There's no need to go over the bridge to receive that kind of care anymore, and that's some of what we'll hear about tonight. I'd like to introduce our first speaker, Dr. Rahul Shah. He's a fellowship-trained, board-certified spine and scoliosis orthopedic surgeon. He specializes in spinal disc and degenerative disorders of the cervical and lumbar spine. He received his medical degree from Robert Wood Johnson Medical Center, and he completed a residency at Yale University and went on to complete a spine surgery fellowship at the University of California in San Francisco. He's a member of the American Academy of Orthopaedic Surgeons and a physician with Muir Orthopaedic Associates that's located here at Tomlin Station Park, and they also have offices in Elmer, down near our Elmer Hospital, and they have an office campus in Vineland and an outpatient surgery center there in Vineland as well. And he's a member of the medical staff at South Jersey Healthcare, both Elmer and the Regional Medical Center. So please join me in welcoming Dr. Rahul Shah.
Thanks for having me. Those were a lot of words. I'm here right next door, and I'm here to take care of people, everyday people, trying to take care of, figure out what's wrong with them, and figure out what we can do to get them better. So that's what we'll talk about today. This talk is kind of set up to kind of give you an idea in broad categories about what back pain is. You know, there are some statistics, and there was just an article in the paper yesterday in which they quoted me. It is true, about 80% of us will have some level of incapacitating back pain at some point in our lives, 2, 3, 4 days. And, you know, that seems like a really high statistic, but it's true. I mean, you know, back's pretty important for us. It's pretty important for us to get around and do anything that we want to do. And so when our back goes out, we have problems. And so it's important for us to understand back pain and understand the components of back pain. And to be very frank, our understanding of back pain has gotten a whole lot better in the last couple of years, in the last decade or so. And I'll go through my journey about it and tell you about what we can do to try and make progress about it, trying to help you get your hands around back pain in case you ever have back pain or in case you ever know somebody that does, which according to statistics is pretty likely. This is the bone and joint decade. These 10 years that we're living in, and the American Academy of Orthopaedic Surgeons, of which I'm a fellow, is making a big push to make sure that we all understand about the back, because the back is in a very unique position in our body in that it protects our nerves, but it's really important for us to be able to bend, lift, and do all sorts of things. And really, orthopedists in that realm are really important in terms of doing all types of surgery and all types of non-operative care for the musculoskeletal system. We'll go over different types of back pain, diagnosing the causes of back pain, and who's at risk for back pain. So, you know, there are different types of things that we can do for back pain. We can do medication, surgery, and non-surgical treatments and complementary approaches, and we'll go through all these as the talk goes forward. I think one of the key important understandings is what is an orthopedic surgeon? How is that person uniquely capable of delivering care for somebody with a bad back? And what can we do? And so let me go back to the history of back pain type of stuff that has been plaguing mankind for centuries. In the 1950s, when lots and lots of people were just trying to figure out back pain and trying to figure out where things were going, orthopedic surgeons by and large took care of most people with back pain because we were the doctors that knew the most about not only bones and muscles and joints and ligaments, but also about nerves and how they all came together. An orthopedic surgeon is a physician that specializes in the treatment of health, maintenance, and musculoskeletal problems, which includes, as you see, bone, joints, ligaments, tendons, cartilage, and spine. And so for many, many years, for 20, 30 years or so, mostly 85 to 90% of the spine surgery that was done all across the country was done by orthopedic spine surgeons. We not only understood the spine, we not only understood the bones and the joints and the ligaments that are uniquely associated with it, but we also were the ones that developed the latest cutting-edge technology. For example, when I was at Yale and I trained with Wayne Southwick, he not only developed the hip osteotomy, a special procedure for the hip, But he also developed surgery for the neck and the approach to do the surgery for the neck. And it's under his hands that I trained to be able to take care of neck problems, for example. The same is true for the back. Lots of people were doing back surgery, but then people were getting healed in bad positions. All the different types of cutting procedures to basically take people that were bent forward and making them straight again, all came from orthopedic surgeons, and their intimate understanding of the hips, along with the pelvis, along with the spine, which is again a unique level of training that we didn't do that. Over the last 10 years or so, we have noticed that as techniques have become more advanced and we have been trying to move towards the smaller incisions and doing things in a more minimally invasive fashion, we have been, some neurosurgeons have begun to do some work in that field. But in fact, it's not only just orthopedic surgery versus neurosurgery in terms of doing this spine surgery, but it's someone that's fellowship trained. That's the highest level of training that you can get in spine surgery. In this area, there are very few providers. I'm one of the very few providers that have the ability to do that. As a matter of fact, I'm the only board-certified fellowship trained spine surgeon in this area. And so an orthopedic surgeon has an expert in treating the musculoskeletal system and maintaining musculoskeletal health. And this is the overall the education of an orthopedic surgeon. Not only do you have to go to school for a few years to go to college and medical school, but then there's internship, which I did at Yale, as well as an orthopedic residency. We also did a fellowship training. I was also chief resident at Yale, and then was at University of California, San Francisco, where we had people come in from all over the world to have their back surgery performed, because we did not only back surgery, but scoliosis surgery, which is an even more complex form of back surgery. And then years of practice, at the minimum, to become board certified. And I've been in practice now for about 6 years or so. Okay, I've been in South Jersey for 2, and I was in Orlando for about 3.5 before that. And orthopedic surgeons, by and large, we've already went over this. We diagnose, treat, and spend a fair bit of time talking to people about how to take the back strain that they had yesterday and figure out how we're going to prevent future back strains and future back problems, and talk about ways to kind of make progress. So this tells you about the bone and joint decade, and this tells you about why musculoskeletal problems are important, and about how much they really do affect us. Our goal is to enhance and educate people about not only what we can do today, but what we can do tomorrow to help make sure that you don't have to deal with this for the rest of your life. So back pain in general has multiple categories. It can be anything from a sprain or ligament that's pulled, just like you pull your shoulder, you pull your hamstrings. It can also be related to stress, and we do see a fair number of people that we do that. But that's not the first thing that jumps to mind, but it's something that certainly is in the back of our minds. And some people, when they're going through a rough patch in their life, tend to have worsening neck pain, or pain from your shoulder blades, or pain in their low back, or pain that's in other places because there's just a lot on their plate. Poor posture has something to do with the spine, and sometimes it's what's going on inside the back that's causing the poor posture. So you're really dealing with a chicken or the egg problem, right? Which is first? And that's something that we really uniquely identify in my practice and in all orthopedic surgeons' practice. Arthritis is clearly something that's important for us, and we all go through. All of us have parts that wear out, and that's what arthritis is. And sometimes those parts, and we'll go through this as the talk continues, can cause some difficulties with the nerves that run next to those parts that wear out that cause us to have pain. Disc protrusions and other causes can also cause back pain. Symptoms include throbbing, aching, shooting, stabbing, dull, or sharp pain that can vary throughout the spine. And you can have pain that can go down the back of one leg or both legs. You can have numbness or weakness in the legs. Those are all signs that the back could be affected. And there are some people that come in and tell me, listen, my calf is really bothering me, my back of my leg is really bothering me, and in fact, it turns out that they have a problem inside one of the areas inside of the low back. Some people do have problems with sleep and decreased energy and anxiety. And what happens is that some people really feel as though when their back really bothers them, somebody has turned up the volume on life. Any little thing gets to them. And it's all because it takes so much power, so much concentration to deal with what's hurting, that everything else can just, it can just become too much to deal with. What are the treatments? What can we do to try and take care of this? In broad categories, what we try to do is try to modify people's activity, try and give them some medication to help calm down the initial irritation. And then, what we really do try to do is avoid inactivity, which, you know, if you say your back is bothering you, some people will say, well, just go and rest in bed. And in fact, that tends to worsen things. And so what we try to do is try and get some medium where you're doing some activity so you're keeping things limber and in shape, but you're doing some activity to try and help get your condition of your muscles, ligaments, bones, joints into a more functional area. So with that, it comes naturally rehabilitation, and we're very lucky to have a world-class physical therapy and rehab facility right next door where many of my patients do go there. And they find that with that, they get an increase in their muscle strength, increase in their flexibility, and improvement in their aerobic fitness. This diagram basically boils down what the spinal column looks like. As you can see, right over here is the neck area or the cervical spine. This is the mid-back. This is the area right where the rib cage are. It's called the thoracic spine. And it's attached to the thoracic spine rather than the thoracic ribs or the rib cage. The low back is the lumbar spine, but that's the low back thing that we had. And then you have the sacrum and the column. This tells you about what the spine looks like. So if you were to go back to here and take one piece of this and blow it up, this is what that would look like. And here are a couple of important things. This is one bone, this is another bone, and in that, each of these bones is like a ring. And through that ring travels the whole spinal cord and spinal canal and the nerves that are important for our function. In between the bones, because we're not stiff, those bones act like little links or a chain. And so that goes through, there's some motion through the disc, and there's some motion through the joints in the back. And each of those links, each of those things are not stuck together like a stiff tube, but it's a very pliable tube, a pliable chain, a pliable set of links, if you will. And each one of those can give you problems. And your spine basically functions to hold your head over your pelvis and allow all the nerves, which is shown over here, to pass safely through that area. And so what you want is to be able to talk to a physician that's able to understand these two different functions. This shows you all the muscles that are attached, and each of these muscles can be pulled. And there's on one of my studies that we did when I was at Yale, about 280 muscles that attach to the neck alone, forget the lower back. So you can understand how complex this is, and so you want to understand how these individually interact so that you can kind of make progress with that. After headaches, back pain is the second most common cause in this work. And 8 out of 10 adults, as we had talked about earlier, will likely have some of this difficulty. It accounts for a whole lot of this kind of work, and there are things that we can understand. So I thought that it'd be helpful to give you some information about people that I've either taken care of or people that we've taken care of during my trainings. And the next person I want to talk to you about is Rahul V, who's an Olympic equestrian, age 44, and he had a significant amount of low back pain. And what ended up happening for him is he had a disc that was pressing on the area of the nerves, giving him pain that was not only in his back but going down his leg. And so for him, when you took a look at his MRI scan, you saw that the channel through which all the nerves were going to go through was getting blocked off by this disc problem. And so we had talked to him about things to do for him, and for him, we ended up doing a laminectomy and opening up the area where the nerves are squashed and giving him enough ability to go back and compete in the Olympics. And it's actually interesting, a friend of mine who's an orthopedic surgeon out in the Midwest near Chicago, a guy by the name of Dr. Su, HSU, just was talking about NFL football players that have the same problem. And did you know that with orthopedic surgical care that these NFL football players that are clearly experience significant amounts of loads, in fact, have returned back to twice as many games and played twice as long with surgery than those that decided not to have surgery. I'm looking at that over some time. So these are all things that I think are very interesting and pearls that, well, you wouldn't otherwise think about, because everybody knows somebody that's had back surgery and has not done well. Other causes of back pain also include spinal fractures, arthritis that we talked about, and that's also known as lumbar spinal stenosis and chronic back pain syndrome. Another person was Conchita, and she was a 41-year-old lady who had a significant amount of discomfort with a large herniation. And her herniation was so bad that, and you can see this over here, this is the area throughout which the whole nerve should be. So, this over here represents the nerves, but they should take up this whole area. You can see that there's this that's basically squashing. As a matter of fact, she was so bad that she was having difficulty pain. She was having difficulty with moving her legs, and she had to be gone to the hospital. I ended up taking her to the operating room and opening up her spinal area. And in fact, she got most of her function back. But this can be a quite serious problem. So if ever people have those types of difficulties, we want them to get medical attention quickly so that we can try and get things done. So one of the questions you want to know is, am I at risk, right? Are you at risk? And those people that are at risk are people that have significant bending and lifting requirements, and it's mainly twisting. The easiest way to hurt your back is to pick up a paper clip. And you think, like, that doesn't seem so hard to do. And the reason is, and it all goes back to understanding the ligaments, the bones, and the joints, is that whenever you pick up a paper clip, when was the last time you picked up a paper clip from the ground and it fell exactly where you wanted it to? Never. Never. So, you're always bending and twisting, and that bending and twisting places such a torque and strain on the back that it causes it to oftentimes behave in ways that it's not typically designed to do. So, if there's one thing that you can take away from my talk today, is that, well, if I ever see a paper clip on the ground, I'm going to face it head on and pick it up head on, as opposed to bending, twisting, and reaching over to get it. Because that's probably the best that you can do for your back. Being overweight certainly does not help someone with back problems, and people that do not exercise and do not engage in recreational physical activity are also at increased risk. And smoking also tends to make it a little bit harder. And the reason for that is because there is, inside when you smoke, there's nicotine inside the cigarettes, and that nicotine, so the nicotine patch, will squash down on the blood vessels and make it 5 times harder for any back problem to heal. As a matter of fact, we did some studies at Yale where we gave rats nicotine, and we saw and we were able to show pretty clearly and convincingly to the entire medical community that we were able to, in fact, make it 5 times harder for the rats to heal. You can just imagine for humans how that would be similar as well. So this shows you about things that you can do every day, things that you can do. Plan ahead, don't hurry, move in close whenever placing objects high on a shelf, and lift with your leg muscles, bend at the knees, and don't twist. That's the most important thing of this. And don't twist to pick up a paper clip. And it's always nice to be able to spread your weight apart so that you're bending, so it's easier to bend with your legs as opposed to bending with the back. If your legs are closer together, you go to bend, you're more likely to bend with your back. If your legs are squatted apart a little bit more, it's easier to bend with your legs. All right, so you got that. Who should you talk to? What should I see? What should I try and do? I would recommend to you, I'm a super specialist, right? I mean, I'm an orthopedic surgeon, I'm a spine surgeon, et cetera, et cetera. I would recommend talking to your regular medical doctor initially and talk to them about what you can do. Oftentimes there are little things that you can do to try and get things better. If your pain continues to last for 4 to 6 weeks, it just doesn't seem to be getting any progress, and seeing an orthopedic surgeon is a good idea so that you can at least take a precautionary move to try and make sure that you take care of simple solutions so that you're not making your problem worse. After you see an orthopedic surgeon, if you're not making progress, seeing a spine surgeon may be of help. If you're thinking about doing operative interventions, other non-operative specialists include physiatrists, pain management doctors, as well as neurologists, as well as anesthesiologists to help you with that. Before you go for your appointment, it's important to know exactly where your symptoms are, make a list of your medication, gather your medical history, and write down concerns that you have. How many times have you been to a doctor and you forgot to say what you wanted to say? It's happened to me. And I can just imagine how tough it is for everybody else as well. So by all means, that's something to do. I welcome it. I had one lady that brought to me, and this happened 2 weeks ago, 16 pages of questions. I didn't know you could have that many questions. Well, we went through each of those questions, and you know what? Some of the questions repeated, and some of the questions were asking the same thing in a different way. But at least we were able to get to answering the questions. And she walked out of there knowing that that was her problem, that her problems were being solved, because those were her concerns, and that was keeping her alive. And that's important to know. Most people don't bring 16 pages of questions, so I feel like you're not doing your job if you're not going to get 16 pages. Exercise is the key. Important, one of the things that I really emphasize, and like I said, it is good that we have a facility right next door, is we try to get people to stop doing what they do typically to make themselves worse, what exercises can they do. So we try to do that, and there are specialized back schools and back programs. And the goal here is not to go to physical therapy forever, or for a week, or for 6 months, but to find out what you can do at home and to make sure that you're doing it right, so your exercises are actually helping but not hurting you, which is another possibility. When you're at your appointment, important questions to know is what I should expect from treatment, what effect will my treatments have on my daily activities, and what can I do to prevent further injury, just like we were talking about. Exercises include running, jogging, playing tennis, getting on a stationary bike, recumbent bike, and different types of other activities, recreational activities. Different stretches are helpful, and going to a physical therapist would be of help. You're always welcome to go to our website. We have a lot of these exercises listed on our website with videos, so that you can at least have a good understanding of what things can do. Sometimes physical therapy and exercise and stretches don't cut it. Sometimes you have something that's more. And sometimes you want to have an intermediate step between going from living with it to having surgery to just exercising. And that intermediate step is pain management. That's a pain program, and that includes different types of medication. Sometimes we can talk about ways to change that medication and to make sure you balance the side effects of the medication versus the results. Ultrasound guidance and water therapy are also important along with TENS unit. Traction and corsets and braces we sometimes use as well. There are 8 important questions to ask your doctor about medications. Number 1, why am I getting this? Number 2, how will this help me? Number 3, what are the benefits and the risks? And how do I take this medicine? What are the side effects? Is it okay to use a brand name versus a generic? Does a generic exist? Will my insurance cover it? And can I take this with the other medicines that I'm taking? And how do I stop it safely? Once you have a clear understanding of that, then you'll be able to use the medicine more effectively. When I was at Yale, we worked with the Bayer Foundation, Bayer, the people that make the aspirin, and we did some interesting work where we found that only 30%, get a load of this, 30% of prescriptions are either filled or taken the way they were intended. That means 2 out of every 3 prescriptions that I write don't get filled or taken. And I don't think it's because people don't want to take their medicines. I just think that you get confused. You don't know exactly what to do. You don't know who to take it. I mean, it's pretty important. Do I need this? Is this really important? So the goal is that if you're going to get a prescription, you're going to get the medicine. At least get enough information about it so that you know exactly how to use it and what you're going to use it. Different types of medications include pain medicines, anti-inflammatories, muscle relaxers, anti-anxiety medications, and antidepressants for some people that have increased stress. If the medicines don't work and you're seeing your pain professional, your pain doctor, other treatment options include trigger point injections, facet injections, sometimes epidural injections where we put anti-inflammatory medicines right next to the nerves or next to the area where we think is causing the problems, and selective nerve root blocks, which is a different type of epidural injection. Surgery may be a good choice when leg pain is worse than back pain, when conservative treatments have not been effective, when symptoms that you have match exactly what's going on in your MRI scans, and they prevent daily activities. The key question is, once you've done all that work, who should you talk to? I mean, everybody knows a surgeon, and everybody knows of a surgeon. So, what kind of surgeon should you look for? I think that one of the things that is important to ask a surgeon, if you do decide that you want surgery, is why should I get this as opposed to just living with it? What are the benefits of it? What are the alternatives? And how long can I expect for these benefits to last? And some things last for a little while, some things last for a long time. And clearly being candid about that. And one of the unique things in spine surgery per se, which is what I do, is that there are trade-offs that have to be made. Do I get scar tissue for this? What is the effects of that? Do I become stiffer because of this? Do I become more mobile because of this? Those trade-offs are an important place to focus your discussion so that you have a clear understanding of what to expect. What are the risks? What are the benefits? What's the name of the procedure? How is it done? Do you have a picture? Can you show me the results? Those sorts of information can then give you a better handle on what it is that you have, and then that can give you a better understanding of what to do. Now, what I do in my practice, and this is just what I do in my practice, is I try and talk to people about show them exactly what the problem is, try and show them exactly what kind of surgery would be done if they're a candidate, what the risks and benefits and the alternatives are, so that they have it very clearly laid out for them. And that's not something that everybody gets a chance to do. And then once we do that, we also talk about what the duration of recovery is. How long can I expect to stay in the hospital? Can I do it as an outpatient? Now, one of the things that I have done, I've done major neck and major low back surgery and have people sleep in their beds that night, and that's something it's nice to be at home, to have that done. And it's not because I'm kicking people out. If they need to stay, we let them stay. But by and large, most people are able to go home for the selective procedures to go. So that's not only minimally invasive, that's outpatient surgery. For the spine, that's a little bit. And I want to tell you that I've done in the last month at least a half a dozen of these. So we do this from time to time, and it's the right thing. What would be the disability after surgery, physical therapy, returns from activity? We go through that. So as you can see, back pain has a multitude of therapies, medications, surgeries, and complementary approaches to help you. And so to get more information, go to this website, AOS.org, or you can go to our premier website at poasnj.com, is it? And take a look at that. There you can read all about me, look at my picture. And on there are links for spine injury treatment and what can be done. I want to thank you very much for your attention. If there's any questions, I'll be happy to answer. Within 6 weeks. 6 months or a little bit more. If within 6 weeks it's not making progress, then we want to make sure that we take a look at that to make sure that's there. But the 6 months is true, but 6 weeks, about 80% will heal itself in this first 6 weeks, and about 85% will take 6 months. So you see, you're not getting a whole lot more for that extra 5 months of waiting or 4 months of waiting. So you may as well just make progress. Well, not all back pain is the same, and the issue is that if you don't know what you're dealing with, then how do you know what to do? For herniated discs, by and large, what we found is that typically in 6 weeks, if they get better, they get better. But those people, and actually when I was at UCSF, we did a study across the country, but we said to 50 people, listen, you have a herniated disc, you get surgery. 50 people, we said, no, we don't want you to get surgery. We're going to follow you over 2 years to see how you do. Did you know that 95% of the people that we said don't have surgery end up having surgery? Even though we don't know how to. Because it's not ethical to say no. But you can see how much that, so the natural history for certain types of herniated discs are not good.
What if you have all the things you mentioned at the spine and don't know where to go, and your family doctor just said no? Scoliosis, herniation.
Right. Well, scoliosis is probably the most complex type of spine problem there is. Most people are not trained to deal with scoliosis. Scoliosis, of the spine fellowships, and there's probably about 60 in the country, I want to say only about 6 or 7 deal primarily with scoliosis. So it's really small.
Give me epidural, like I have everything else on, but I'm still in pain.
Yeah.
I don't know the root for it, what's left.
Right. And so seeing a scoliosis expert is probably a good idea. And then talking about the trade-offs is important too. Because it may be that if you have all of them, which is the most important, which is the one we want to address. Because there are trade-offs with any type of intervention. But yeah, seeing someone that's a musculoskeletal specialist and a scoliosis specialist is probably important.
Yes, I've already had a discectomy, and I'm going through the
I think by and large, the question is, how am I certain that what they're recommending to me is likely to work if I still have a significant amount of disability? And that, again, is where that trade-off discussion comes into play. In seeking somebody out that has a significant amount of information, a significant amount of understanding of people that have done that. And I have put in both the pain blocking signals and have done revisions on on the spectrums of mine and other people's because they would benefit from another procedure. So at some point, you just have to figure out what the trade-offs are and what's the likelihood of helping that. Now, if the pain management doctor has not done a lot of the fusion procedures, has not seen that spectrum, and seeing another independent person to weigh in on that might be a good idea. Or at least getting somebody that, I don't see that as a second opinion, I just see that as somebody weighing in on that to say, well, this is what my problem is, what solution is likely to help me given what I have? And when you have something that's that unique, it's good to have somebody that gets an independent look at that, which is, which I think is a little bit different. Maybe it's the same thing, but in my mind it's a little bit different than just saying, well, I'm getting a second opinion. I'm trying to get someone else's idea as to exactly what's happening here, and not in any contentious way, but more in a collaborative way.
On the pelvis, the bone at the bottom.
That's right.
If that is broken and separated, how much does that hurt the back?
So here's the other secret about spine surgery. It all depends. The reality is it does depend, and it depends on how can you isolate the problem, okay? How can you isolate that it is just that and nothing else that's causing the problem in the back? So the more
Well, there is
important
a lot
question,
of other things.
that's the point. So how can you isolate one versus another?
Can that be fixed, that bone if it's broken and separated?
It depends on how bad it's broken and to what degree it's
All that.
separated.
1
And,
centimeter.
and like I said, I can't comment on individual things, but I think that if that gives you the typical type of problem, then maybe that can be fixed.
Is there a way to pull bone back together?
Sometimes.
Is that something that you do?
I've done it. But for the right people, it's done. For some people that haven't, I haven't done it because that's not always the right thing to know about. Go ahead. What do you mean by spinal decompression? Are you talking about the decompression that I will do? Or is it the one that you get over the phone? Or is it the one that you go to somebody where they just stretch you out? I mean, because that term is used in many different ways.
There's a DPX 9000.
Okay, all right. So I was in Florida for 3 years. I had that question all the time. Florida has lots of chiropractors, and we work closely together. I think that the bottom line is that traction does work while you have it, but the problem is you can't live on that machine. So if you're able to get some significant relief initially, then that's great. But over time, if you keep having to go back to that same thing, your main problem is when you're off the machine, and that main problem is gravity, and that's the larger issue that has to be done. So there are times when that can work very well, but that's a very small amount of people. And so if you do not get significant improvement within a few weeks, that's sustained, and I would probably look at other choices. By and large, in the low back, it typically does not, provided that you do not have significant scoliosis, and provided that you do not have significant other nerve problems like multiple sclerosis and the like.
Dr. Shah, can we take maybe one more question and bring up our next speaker?
Sure.
And would you be willing to answer some questions after the session ends?
Yeah, sounds good.
If you have a torn disc and it's also bulging, do you have to get fusion for that?
Sometimes, again, it all depends on the problem itself. There are times when we try to not do a fusion for that problem, and sometimes we do a fusion for the problem, depending on the set of symptoms that one has. And that same problem that you have can be, we watch it, to we give it some shots, to you take some medicines, to you get major surgery, both the opening of your belly and your pelvis and your back. So there's a whole spectrum for that. And so the reality is that having a good relationship with the physician that you're using will help you make the right choice.
Yeah, Dr. Smith Martin is my pain management doctor, and she gave me all the shots, and she said because it's torn,
Yeah.
the medicine's gonna stay, and in fact, she told me to come see you.
That's fantastic. So, I think that the one thing about Dr. Smith is that I think that she's pretty straightforward. So if she's giving me that information, I think that there might be some truth. I think that we have time. Well, thank you very much for your time.
Dr. Shah's going to hang with us for a little while, so if you'd like to meet him before you leave tonight, please feel free. And I'd also like to introduce Nick Coffey in the back from your orthopedics. If you have any other questions about our orthopedic practice, Nick could also help you and provide you some information on how you can visit them or make an appointment. I'd like to bring up our next speaker. We'd like to, because we're here at the Imaging Center, talk a little bit about how imaging can support our physicians who specialize in orthopedics, like Dr. Shah. And Dr. Nitesh Bhagat is here with us tonight. He's a board-certified radiologist specializing in musculoskeletal and neuroradiology. He received his medical degree from Wayne State University School of Medicine at Michigan.
I will be seeing.
And he completed his residency and fellowship here in Philadelphia at Thomas Jefferson University Hospital. He's a member of Regional Diagnostic Imaging.
Wherever you need it.
Okay, you can be here.
And Regional Diagnostic Imaging is the radiology group here at South Jersey Healthcare. And they're one of the region's largest and most experienced groups. They have many radiologists who are fellowship trained in specific areas of radiology, which helps our physicians who provide that expertise, university level expertise right here in our community. And we're very excited to have them as part of the South Jersey Healthcare team. And they bring that expertise right here to Tomlin Station Park, our imaging center, and we're proud to welcome them here at Mullica Hill, the imaging center. So please welcome me in joining us.
Yeah, I know, I passed, so I want to and my sister's mother-in-law sees him. But they keep saying no one knows what to do.
Thank you for attending and thanks for having me. Everybody hear me okay? All right, so I'm going to discuss what radiology is about. Obviously, we go see surgeons, we see your doctors, we go get an X-ray request, MRI request, CT request. How many of you ever had an X-ray? Probably the majority. How about a CAT scan or a CT? Not so many. And then how about an MRI? And then how many of those go actually with an MRI looks like what a CT does? What does it show? Not so many people. So that's what I want to try to show you today. What do we see in back pain specifically? And you know what we can tell the surgeons. And when you go to the office and you examine you, and they see certain spots. Okay, you hurt here, maybe just nervous, you know, being compressed or something. But then they get the MRI or the X-rays or the CTs to kind of show you, confirm what their exam findings show. So, you know, back pain, again, Dr. Shah elaborated on a lot of these issues, but bones, joints, ligaments. I mean, there's a lot of stuff back there, as you alluded to. So those are the major causes. And when they degenerate or when they're not working as they're supposed to, you get back pain. Disc bulges and herniations, I'll show you some pictures of that just so you have an idea of what actually a herniation means. What does the bulge mean? That term gets thrown on all the time. You know, I have a disc herniation. Well, what does it look like and what symptoms does it cause? So I'll show you that stuff. Osteoporosis is a big factor. When you have weak bones, they can fracture easier, and that can cause back pain because you find, you know, a lot of bones back there. And then scoliosis we'll touch on too, and then some minor other causes. So like we said, what we use is X-rays, MRIs, CAT scans. DEXA scans is another thing that diagnoses osteoporosis. So when you have osteoporosis, how do you know your bones are weak? How do you know your bones are going to break or increase risk for breaking? So I'll show you what we do here for that stuff. So X-ray, this is the first step, the simplest study that we see. And X-rays are good for bones. I mean, you can see this is the cervical spine or the neck spine, and you just see bones here. And then you don't really see the spinal cord, you don't see the nerves, you can see a whole lot of other stuff with it. So we can, turn your head one way or another, and then these holes that are formed here is actually where your nerves come out of, those holes. And when you start getting arthritis and degeneration in your spine, those holes start to narrow. And as you can see, your nerves are coming out of each of these holes. If that hole narrows, obviously it's going to compress your nerves and that's going to cause symptoms. Here's just an image of your thoracic spine, or the back, and then these are the ribs that Dr. Shah was talking about. So that's the main spine that just is right up here, and the low back is your lumbar spine, which is your lower back. And again, in X-ray you just see bones, and then this space right here houses your spinal cord. So this bony canal is what you have that holds your entire spinal cord in there. If that narrows, if that somehow shifts, if these bones shift backwards or forwards, that can lead to compression of that. So here's what a CAT scan looks like, and this is how we look at it. We can go from side to side, and we can actually show you. So now you're getting a little bit more detail. If you look from the X-ray, now you get bones, and then you get soft tissue, and this is actually the spinal cord, this gray thing sitting in the middle of the canal. So you see the bony canal. This white stuff is your bones, and then the ring that it forms, this canal, is what houses, your spinal cord. And everything that travels down here, all these nerves travel down the spinal cord. So that's what we're interested in. That's what we want to try to, this space we want to try to preserve as maximally as you can, to have it nice and open so that your spinal cord is breathing room. So we can do that, and then here's just thoracic spine, same kind of thing. You have a bony canal, and then you have a long tube of your spinal cord that goes down it. And then just in your lumbar spine, same thing. And that's what your lumbar spine looks like. Bones, again, same thing, bones and soft tissue. So, and then that's how we actually look at it. We go back and forth and see if there's any bulges or not. So these are what the bones are look here, and then right in between the bones, it's not white, that's your discs. So your discs look like that, and your bones look like that. And these are labeled accordingly. Like this is T12, these are T12, vertebrae, and so I think some of you probably know what your levels are, L4, L5. That's what we mean when we have disc levels, when we use that terminology. So in MRI, now you're getting into more detail. So see, this is just building up. X-rays are good initial steps, and then you go to CTs maybe, but MRI is what the money's at. I mean, that shows you pretty much everything. Now if you look here, that's just the whole body MRI of your entire spine. There's a little bit of brain up here too, but this is the spinal cord. This gray structure going all the way down to your lower back. And then this is the canal that it's housed in. And then here's your cervical spine again. And then you can see it really nicely. And we can scroll through it back and forth, and we can see any disc or something. So here's your spinal cord, the gray. The white stuff is the fluid that it's floating in. That's what cushions, that's a shock absorber that surrounds your spinal cord. And you want a lot of space, a lot of fluid around there, so you have a nice shock absorption, not too much narrowing in there. And then these are your bones. These things, and the white things in between, those are the discs. So you can see very clearly, very detailed anatomy with MRI. Same thing with the thoracic spine. You see the spinal cord in the middle. You see the disc, and then you see the bones around it. And then you can manipulate these images any way you want to. And then here's your lower back. Your spinal cord ends about the 12th level. So most of your lower back, there's just nerves that come down. Most of your spinal cord is ended here. So now when you have these long roots of nerves, you can actually see these little wisps of cord. See these little strings? Those are actually each individual nerve going to specific parts of your muscles, your legs, your hands, wherever they need to go to supply so that we can move, you can feel, you can touch and figure out what's going on. So again, here's what the differences are. You have X-ray. Good for bones, good initial start, but you're not really seeing spinal cord here, you're not seeing nerves, nothing. Here you're seeing CAT scan, you're seeing a little bit of soft tissue, but not so much. But MRI, you get the whole picture. You get the spinal cord, you get the fluid around it, the discs, and everything else. So just the anatomy again. So here it is. And this is taken as a cross section of the spinal cord at one level. So here's the spinal cord, this gray oval, and then the white surroundings thing is the fluid that bathes it. And then the bones is right here. That's one bone, and then this is a bone right here. So there's a ring here. You see that? That's the canal. That's what we refer to when we say spinal canal. So that needs to be nice, white, and open. And you can see if it narrows, you're going to get symptoms. And I'll show you pictures of that. So again, here it is. There's the bone, and then that hole in there is where the spinal canal, a cord travels through. So this is what we mean by degenerative disc disease. people always refer to degenerative disc disease. So here's a normal disc, what it looks like. When it degenerates, first it narrows, and discs are a lot of water. When you start to degenerate, you also desiccate, which means you dry out. The discs start to dry out, and we can see that with MRI. And then they eventually start to bulge like this, so they bulge out. See, here's the canal, right? Right now, the disc is nice and tucked away. Here, it's starting to bulge, and it's starting to narrow the canal. And then a herniation is just a focal bulge. It's not the whole disc doesn't go, but just a little piece of it goes out and kind of pushes and grabs the cord. And that can cause a lot of pain. And then eventually, if you get really narrow to this, and you get a lot of bony stuff, that can cause a lot of back pain. So here's just an example of a bulge. If you look, this is the normal side. And if you look here, there's a huge bulge here, and this is the spinal cord. And watch what it's doing. It's coming down nicely, and then all of a sudden it kinks. Now, if you're pushing on your cord like that, rest assured it's going to hurt. I mean, that's what back pain looks like. And here's a really, severe case. Now, if you look at this example, nice and open spinal cord, right? The discs are nice and tucked away in here. If you look at this case, look at all these discs. They're just jutting into the spinal cord. Look at that. This is a normal level here. Right? See, you have nice white, the fluid around the spinal cord, bathing it. Down here, you're getting a lot of discs. That's basically just jutting the spinal cord from the back and from the front. These are ligaments back here. So this is what degenerative disc disease looks like. And this is what they mean when they want to open it up or decompress you. This is all compressing here. You want to try to relieve some of that by decompressing. Here's another huge disc. I mean, this is a huge one that basically, here's the spinal cord, and it's just basically being pinned up against the bony canal. So this is what, back pain really looks like in MRI. Here's another case. This is what I meant by, the disc desiccator, they dry out. When they're nice and bright like this, they're filled with water. If you can see this one, it's narrower than these, and it's also a little blacker, which means that's what an MRI finding, that's what it's starting to do. It's starting to dry out, and then also narrow, and then eventually it's also starting to bulge. If you look here, you're getting it's bulging right here, right? Compared to these. So those are what's causing back pain. Now here, if you keep your eye on this level right here, watch what happens. There's a disc right here, right? And then if you come out, you see that? That little ball, the little gray ball, that's what a protrusion or a herniation means. So when they say you herniate your disc, that's what it means. Look at the disc here. It's sort of tucked away, it's bulging. But as you're coming out here, you see that little outpouching right there, that gray? And then these are the nerves right here. These things right above it. So those nerves are getting pretty much pinned and smashed against that herniation. And then here it is on this side. Now keep your eye over here. I'm going to go over. See this right here, this little black dot? That's one of your nerve roots. And all of these little black dots in here, they're all little nerve roots that's going to go all the way down your spine, your leg, and provide motion, sensation, wherever it needs to go. So just watch this root right here as I scroll through this. It's gone. There's a little gray there, and then there's another gray there, and then there's a little lump right here, right? And that's what a protrusion looks like. That's a herniation. So that disc, this is the whole disc right here. So the disc should be nice and round right here, and this should be the border of it. But if you look at this disc, it's coming around like this. So that's a focal, just kind of just tore, and some of the disc material kind of just squeezed out basically, and it just basically touched on that nerve root, and that can cause it's just like your funny bone. You get your funny bone, right? That's a nerve. So you push on it, you get that tingling feeling, that burning. That's what you get when you have a herniation. So that's what a herniation looks like. And again, MRI tells you all this. You can see exquisite detail. You can see every little nerve root discs. With that. And here's just another example of what a normal level looks like. And then if you come down here, look at how much room there is for the nerves to come out. It's basically zero. So if you scroll through it, look, there's no white stuff there. So here's what a normal level looks like in cross section. Nice, wide, and open. Nice nerve roots there. And here's what a abnormal level looks like, which is corresponding to this level. You can see how bulging this disc is. Posterior and behind, it's also getting squeezed. And if you look at these two levels, we're going closer here. Normal level, completely, there's no white here. This is all basically your ligaments that have enlarged to kind of compensate for the pain. And this disc is bulging, basically left with no oval in here. That's where your cord travels, that's where your nerve travels. So this is what radiology does. It images all of this. some degenerative stuff. Now, here's just an example of scoliosis, just so you know what it looks like. That's a normal straight spine. Scoliosis just means that it's a bent spine. And we have measurements that we can take to give to the orthopedic surgeons that, tells you how much of it's bent, what's bent. There's a lot of factors that can cause bending in your spine. Most of it is just you're born with it that way, but there's a lot of other things that can cause it too, and that's what we want to make sure you don't have. And again, MRI will be good for that. Last few minutes, I just want to touch on osteoporosis because that's a big factor in back pain. In that once your osteoporosis means osteo is bone, porosis is porosity, so it's holes in your bone, right? Your bones are porous. So just like this example shows, like here's a normal healthy bone, and then here when the bones start, getting porous as you get older, that's what it looks like, and that's actually a real image of it, of a real spine that's taken with a microscope. This is normal bone, and these are the huge holes that your bones leave. And then as you can see, that's easier to compress and break when you don't have as much bone in your bones. So how do we diagnose it? DEXA scans, what we use to diagnose how thin your bones are, how strong your bones are. And if you've ever looked at your DEXA scan, you'll have a T-score, and I don't know if you've ever looked at it or what that means, but this is what the T-scores mean. A T-score compares your bones to the bones of normal, healthy males or females in your respective age. You go for 30 years old because that's when the peak bone mass is of any individual for us. They're the least likely to fracture a bone just because of weight issues or because of the weight. So that's what you compare it to. And then these are your scores, which actually the report tells you on what it means. So this is just what it looks like. What we do is basically take a very low dose X-ray and we shoot it through your spine, and then we get a picture of it. And based on how fast those X-ray beams shoot through the bones, the machine can tell you how much of it, how much bone density you guys have. And certain scores are higher, certain scores are lower, and then the osteoporosis basically means that you're increased risk for fracture. Osteopenia, which is not as bad as osteoporosis, means you're at an increased risk but not the highest risk. Osteoporosis means you're probably at the highest risk. And then that, we need to do something before it gets to the point where we actually would break something. So this is what a compression fracture looks like. And again, back pain, when you have osteoporotic bones, they're they're more likely to compress. Remember, you're carrying your whole weight on your spine, and if you have spongy bone, it's more likely to collapse. So this is what a normal square vertebral body looks like, a bone in your back. There's the disc, and if you look here, that's a compressed bone, and that's what an X-ray looks like. It's a compressed bone here, as compared to a normal bone here. An MRI is kind of needed to tell you if you have an acute injury or not, if it just happened yesterday and you have back pain, chances are it's good, it's recent. But some people fracture bones maybe last year, and then the X-ray will look the same. Now you don't know if that is something that happened yesterday or not when you're looking at the films. And sometimes you have back pain for that whole year, even if the back pain is from the fracture or something else. So an MRI can tell you, see this, it's right here, that means that it happened recently. So the MRI actually can tell you, that's called fluid. When you see fluid on MRI, it's bright on certain images. And so we can tell you whether that happened now or it can happen a year ago, maybe something else is causing your back pain. So that's the other reason to get back pains. Here's a very severe fracture. You can look at the CAT scan here. Basically, the vertebral body, the bone here just really collapsed down. But here, if you look, this patient came in with back pain, but when they got an MRI, there's no white stuff in this. That means this is an older fracture, and it's probably not amenable to the standard surgeries that we can be done, or you can put it in terms of kyphoplasty, vertebroplasty, where you can actually inject the bone and actually fill it up a little bit to prevent pain. Well, in this case, when you don't have edema, when it wasn't acute, it's not going to really help you. You've got to look for other causes. So this is the other thing MRI is really good for. Bone scan is the other thing that's good. And this is what a bone scan looks like if you've never seen one. It actually will give you a dye to put into your, vein. And then basically that dye goes to every single bone in your body. So basically it's highlighting your whole skeleton. So it looks like a skeleton because it is. That's a real patient's bony structure. And that's what a bone, and if it goes, if there's more medicine or dye going to that structure, the top basically, which I'll show you here. Like if you look here, there's a fracture here, right? Again, we don't know if it's old or not. If you look at the bone scan, there's an area right here that's really bright white compared to the rest of the scan. So that means that the chemical went more there, means that it was more recent. That means that was an acute or recent fracture that can probably undergo treatment and be successfully treated with that, with pain relief. So that's what a bone scan looks like, and that actually, can show you acute or not. So, back pains, again, in conclusion, very multifactorial. Specialists should be reading and interpreting and diagnosing back pain. As Dr. Shah said, he's an orthopedic surgeon. We at South Jersey here, we are actually a fellowship-trained radiologist. We actually are the only group that has fellowship training in neurology and musculoskeletal imaging in this whole region. So there's a lot of practices out here that have radiologists, but it's like going to an internal medicine doctor and then going to a cardiologist for your heart. For certain complicated heart problems, you don't want to just see a generalist, you want to know who's actually trained in it. And just like Dr. Shah, we have actually special training, fellowship training, above and beyond just the general radiology training to read this stuff. So we do that with our turnaround times as far as getting studies done. If you get an MRI scan or a CAT scan, now basically it gets read within an hour or two. That's something that not many radiologists can say. Their usual turnaround time is around 24 hours. They give that window to allow that reading to come back to the doctor's office. If you come in for an MRI scan, by the time you probably go to your doctor's office, if it's in the afternoon, the report is waiting there for them saying, this is what your MRI showed. And if it's really concerning, we call right away. Like if there's a fracture or something that requires more urgent care, then we pick up the phone and we call the doctors. So this is something that we like to do here, and we're good at it, and we're trained to do it. So that's why we're giving this talk, and we sit right behind those doors here, and that's where we read your cases. So thank you for your attention.
What gets to my doctor then is your written report, not the picture.
But the doctors have access to those
Within the practice?
within the practice or a CD. Say, we would always give you a CD. If you come to Dr. Shah, he has access to our images. He actually sees the same images we see in the same monitor system. If it's a doctor that's outside of our system, then we give them a CD so they can look at it. That's always just given with any study.
Can I ask for one if I do?
Anytime. You're entitled to get, not even here, anywhere. You're entitled to your images. That's your record, so you're entitled to those. Yeah.
Do you read MRIs that have already been taken to give like a second opinion?
We give second opinions on the request of the physician, like if the physician would request that. We cannot just, if you bring it in to say, can I get a second opinion? We actually need a script from the physician because it becomes a legal document, like my word. If I'm going to say something, and that has to be at least put on paper. The only way to put it on paper to say that, okay, this is a second opinion. But that's easily done. We do it all the time. But, that's something that would have to come through a doctor to say, can you please do a second reading on it?
Maybe a less trained radiologist would miss something that you would pick up right on.
Yep, and we see that all the time. That's why we get a lot of second readings, especially at our place. Since we are some of the fellows, we have the fellowship training here. So we do get a lot of those for that reason. Yeah.
What is it, Schmorl's node?
Schmorl's nodes? That's when your disc, remember I showed you the discs? If you go back, right here, if you look at this disc, it's pretty flat. See the bone here? This black is your disc, right? So if you look here, this is pretty flat. The bone on top is the right thing, and the bone on the bottom is the other right thing, right? And the disc is in between. So when the disc starts burrowing into the bone like this and starts indenting it, like you see here, see this? Now it's starting to curve. Instead of being flat across, like this one here. So it basically means that the disc is pushing up into the bone. And that's what a Schmorl's node is. This is just a mild bulge here, but you can have Schmorl's nodes that really indent the bone, that go all the way up into your bone. And they can hurt. They don't have to hurt. But again, with MRI, we can see the fluid around the Schmall zone. If we see fluid around that Schmall zone, we can tell you that, okay, that happened recently. Because Schmall zones, you could have had a Schmall zone a year ago, 2 years ago, or yesterday. We can tell you if it happened yesterday, or recently at least, within a treatment period, so that you could benefit from that.
There is a treatment for it?
Well, it's basically, it's not it's basically just, anti-inflammatories and, rehab and that, whatever Dr. Shah said, because he diagnosed it, but it's a non-surgical treatment. But yeah, you have to treat it, If it hurts, there's something out there for it. Yeah.
Of your 3 facilities, Vineland, Elm, and here, is there one that's better than the others for doing a spinal MRI?
They're all equal. And there's only, since we have specialists in every specialty, like say body imaging, head imaging, spine imaging, only the specialists read the spine. Like in my case, only me and 2 other doctors who are trained to read the spine will read the spine. The other people who are not trained don't read these spines. So it doesn't matter if I'm here, or if I'm down in Vineland, I can pull up the images anywhere. It's all connected here, and I would read it. Like if you had a study here today, and I was at Regional Medical Center in Vineland, I would be reading your study from down there. And but yeah, any places we have the same equipment pretty much everywhere throughout the system. It's all very good and updated equipment, and it's just a matter of where you want to go. Any other questions? Okay, well, thanks again.
I'd like to thank both of our physicians for joining us tonight. I hope you found that to be educational. And they're still here. If you'd like to introduce yourself before you leave, please feel free.